presentation on Zika virus.
Thank you. Hi everyone, I'm Dr. Berken. I'm one of the third-year OB residents, in case you don't know me. Like Dr. Briette said, today my talk is going to be on Zika virus, which is very popular in the news, especially with the new news of the Zika case in Caddo Parish. So we'll get started. We do have a patient right now currently that is undergoing testing for Zika. This is not, it has not resulted yet, but, oh, it did? Okay, well, good. Well, we'll very briefly go through this then, since she doesn't have it.
I just got the email right before I came.
But she was a 25-year-old GYN. She came in at approximately 6 weeks and 5 days by her last menstrual period. She was from central Mexico, and she had plans to visit her fiancé within the week. She otherwise had a very normal past medical, surgical OB history. She was just a G1. Physical exam was normal. But then we counseled her extensively, told her you probably shouldn't go. We would strongly recommend that you not go. We recommend if you have to absolutely go that you wear long sleeves, long pants, bring repellent, don't engage in any sexual activity with your fiancé. But she did come back at 12 weeks and 6 days for a follow-up visit, not complaining of any symptoms, but she had returned the day prior from Mexico, so she did go. She stayed there for a whole month during her first trimester, and she visited her fiancé, who had been there for a total of 4 months. Neither one of them was having any symptoms, but she was sexually active with her fiancé while she was there, so we did have a high suspicion that she may have been bitten by a mosquito and could have possibly contracted Zika virus while there. So that prompted us to do ultrasound. When she came in, it was a little early for an anatomy scan, so it was too early to look for major abnormalities, but nothing glaring was seen, and she was just scheduled for a repeat growth when it was an appropriate time. This is the questionnaire that we filled out in clinic. I've cut off her identifying information, but it basically just asks what symptoms they're having, if they've ever had a similar virus before, if they've had vaccinations against yellow fever and a couple types of the viral encephalitis, and it asks where they're going, when, why they're going, and then there's some information on the bottom as to where to send this information, because you have to get approved to submit the test. So the objectives of this talk are going to be to define Zika virus and its known characteristics, explain how it's transmitted, highlight public health concerns, the importance of Zika awareness among both OBGYNs and pediatricians, so it's good that we have both in the room, and then see what testing modalities are currently available, review preventative methods, travel guidelines, things that are pertinent to our patients, and then list some resources so that we can recommend current things to our patients, stay up to date, and then do the right thing if we suspect that a patient at our hospital has Zika or could have contracted Zika virus. So what is it? It's in the flavivirus family. It's enveloped icosahedral virus, non-segmented, single-stranded, 10 kilobase positive sense RNA genome. That means less to me now than it did back in step 1 days. But the majority of the infections are asymptomatic. Up to 80% can be asymptomatic. And it's spread by several ways, but mainly by this certain type of mosquitoes, the Aedes aegypti and the albopictus, which are mainly daytime active, which are a little bit different than some of the nighttime active mosquitoes that we're a little bit more used to around here. It was first isolated in 1947 in the Zika forest in Uganda. That's where the name comes from, obviously. And it is related to dengue, yellow fever, Japanese encephalitis, and West Nile viruses. This is just an electron micrograph of Zika virus. It's been colored. The virus particles are the blue particles depicted here. and you can see faintly that outer envelope with an inner dense core of the virus. So common symptoms, conjunctivitis, fever, rash, and joint pain are the main symptoms, but you can also have muscle pain, you can have headaches, and the symptoms typically last for about a week, several days to a week. People normally don't get sick enough to go to the hospital. Like I said, most of the time you're completely asymptomatic. And people rarely die from the disease, although there have been cases of deaths because of Zika virus. And it's believed that once the person's infected, just like a lot of other viruses, then you're protected from future infections. Currently in the United States, as of August 24th, so just a few days outdated, but I mean they're adding cases daily. So as of August 24th, in the United States, there were 29 total locally acquired mosquito-borne cases. So that means transmission by mosquitoes here in the United States. Travel-associated cases from people that left the United States and then come back was right around 2,500. There was one laboratory case where someone was believed to have contracted it from a lab. 22 sexually transmitted cases, and then 7 cases of Guillain Barré, and we'll talk about that in a little bit. Now in U.S. territories, that's where it's even more of a problem right now, particularly Puerto Rico. Puerto Rico makes up most of these locally acquired cases. That's almost 9,000, and then about 26 cases of Guillain Barré. Here's a map of the United States. So you can see, if you look at Louisiana, we're kind of in the middle. We're surrounded by some states that have more cases, like Texas, Georgia, Florida, but it's pretty much the South, and then a little bit of the Midwest, and then the Northeast, which are a lot of places where people have traveled. A lot of people go down to the Caribbean from the colder states and colder climates, and so that's where a lot of the travel-associated cases have come from. This is a list state by state. You can see Florida has by far the most with the 29 locally acquired cases. That's the only state as of right now that has locally acquired cases. Louisiana, we had 25 when this data was released. Now we have 26. And as of just a couple days ago, there's been a case discovered in Caddo Parish that was travel related, not locally transmitted. These are just the remainder of the states. New York has quite a few. And then this is Puerto Rico. So you can see how many they have right now, and it is growing very rapidly. It's believed that in Puerto Rico, if it continues at the rate it's going, about 1 in 4 people will become infected with Zika. Out of the cases in the United States that have been spread here, it's in 2 areas of Florida around the Miami area, this Wynwood neighborhood and Miami Beach. I'm not super familiar with Miami, but I know Miami Beach is a hot spot for lots of travelers. So obviously that poses a pretty big threat just worldwide, because Miami has a massive airport that has international travel. Something like this can spread very quickly. And looking at a map of the Americas, it's pretty much all of North America, Central America, and South America that are involved. All the good vacation spots, tropical islands, Caribbean, they're all involved. So how does it spread? Most commonly, a mosquito will bite an infected person. There's a 2-week incubation period. Then from there, the mosquito is infected and can then transmit the virus as a vector to an uninfected host with a bite. And then from there, it just spreads and more mosquitoes get infected, more people become infected. It also can be transmitted during pregnancy with vertical transmission through sexual intercourse or through blood transfusions. So a little bit more about the mosquitoes. The first type is pictured right here. The second type, right here, they look fairly similar. You're not going to be able to tell on a quick mosquito bite which kind is biting you. The Egypti mosquito lives in mostly tropical, subtropical, and some temperate climates, which is a little bit different. The albopictus mosquito lives in all of those areas, plus has a little bit further range as far as colder climates go. The Egypti is the main type of mosquito that spreads this and other similar viruses, and it likes to live around and feed on specifically people, whereas the albopictus feeds on both animals and people. Because it feeds on both animals and people, it's less likely to transmit the disease just because there's a lot more animals than there are people around out in the fields. The mosquitoes reproduce by laying eggs in and around standing water. That's why you always hear, if you have a mosquito problem, make sure you dump out all your plants, all the water catch bins, any standing water that you have outside. And then, unlike some of the mosquitoes, like I talked about before, these are aggressive daytime biters. So if you say, oh, I'm going to be safe by just going out during the daytime, you're wrong, because this is the most common time that these mosquitoes actually like to feed, is during the day. Showing both types of mosquitoes here, you can just see the slightly colder climates that the albopictus mosquito likes to reside in as well. So how do you prevent this? On a state level, excuse me, I have a cold, so if I start coughing, I apologize. On a state level, you can do insecticide programs, and they're actively doing that. Backpack sprayers, trucks, airplanes, lots of different ways that you can help cut down on the mosquito population. You can do the same thing around your home, inside and outside. And there's also larvicides that are EPA registered that you can use. How to protect yourself directly: wear long sleeves, long shirts, long pants. If they can't bite you, then you can't get the disease unless you have sexual intercourse, blood transfusion, things like that. There's lots of EPA registered insect repellents. DEET is the most popular. Some of the other ones I hadn't even heard of before, but almost all of them are safe on children older than 2 months old. Also, permethrin. You can treat your clothes. You can buy packs that you can put in your washing machine. You can spray your clothes. And these actually protect through multiple washings, so you don't have to treat your clothes every single time you wash them. And then obviously stay and sleep inside, air-conditioned rooms, screened-in rooms. You can put a bed net, but these are less effective than if these mosquitoes only fed at night. And then mosquito netting is certainly recommended for 2-month-olds or under, just because you can't use some of these insect repellents, strollers, carriers, things to protect the children. These are some common names of the repellents and their brand name. You can use Off, Cutter, I've heard of all of those. Skin So Soft is another popular one. So if you're not quite Repel, if you're not quite sure which chemicals are in which brand names, this is a list right here. These are all approved and all effective, although DEET is by far the most effective and the most studied. So there's a study that was put out just this month. It was in the Green Journal, and it was in August this month, like I said, by Wiley et al. And it looked at all the different types of insect repellents and if it was safe during pregnancy. Basically, in light of people having to protect themselves, were we doing more harm by spraying all of our pregnant women with this DEET, which has kind of been a controversial compound in recent years. So both the EPA and the Canadian Pest Management Regulatory Agency concluded that as a low toxicity does not appear to pose a significant threat. Definitely use it as directed. It's the most important thing. Don't swallow it. Don't spray it in your eyes. Don't overspray. Use it as directed on the label because that's all they've tested as far as animal and human studies. And then just a little bit on DEET. The history, it's been used since the 50s. It provides the most effective and the longest lasting protection against mosquitoes compared to all those other compounds that I listed earlier. Mainly works by actually disturbing the receptors on the mosquito in the antenna, and so it can't find us, which I didn't really know how it worked, but it basically just confuses them, and so they can't smell out people. So they don't know how to get to us, so they can't bite us. With this, the peak concentration that's effective is 50%, then after that the effectiveness plateaus. So you see sometimes there's these deep wood treatments that are 80%, 90% deep. They've studied that really the concentration that's the most effective before you reach that plateau is 50%, so there's no need to use anything higher than that. There is about 5 to 15% dermal absorption from DEET. This was done using non-pregnant adult volunteers. And then it is metabolized by the kidney, and it's fairly rapidly excreted through the kidneys within about 24 hours. There was a randomized control trial in Africa involving just under 900 pregnant women, and this did show that there was no significant difference between the two groups as far as birth weight, newborn characteristics, newborn neurological exam, or the milestones by the first year. And they did even test a group of, they tested cord blood in a subset of that group, and there were 4 of the subset. There was, I believe, about 50 patients. 4, they did detect DEET in the cord blood, and all of those children had no findings at 1 year out either. So mother-to-child transmission during pregnancy, it's basically an infected pregnant woman can pass it to a fetus during pregnancy or around the time of birth. To date, there's no reported transmission through breastfeeding. So given all the benefits that we all know so well about breastfeeding, mothers are still encouraged to breastfeed. Sexual transmission, it can be transmitted even if you're asymptomatic. That doesn't mean anything as far as whether you can pass it on or not, and that's what makes it so tricky sometimes, because 80%, like I keep saying, of these patients are going to be asymptomatic. We know that it can remain in semen longer than any other body fluids, although they don't really know exactly how long. It can also be in urine, blood, vaginal fluid, but they're doing long-term studies right now to exactly find out how long. And then any type of sexual activity counts. So make sure that patients are aware of that. It's not just sexual intercourse where you can pass this on. So how to protect yourself from during pregnancy. Obviously use condoms during sexual intercourse. It's not 100%, but it's better than nothing. All pregnant women with sexual partners who live in or have traveled to an area with Zika should use condoms or abstain from sexual activity completely. And then if you're not pregnant, you should use condoms or abstain for a minimum of 8 weeks. That's the current recommendation right now. You can also transmit through blood transfusion, but as of right now, there's no confirmed cases of transmission in the United States. However, there are cases, particularly in Brazil. There's been multiple reports of this. And then there was a French Polynesian outbreak where about almost 3% of blood donors tested positive for Zika. So current recommendations on blood transfusions, this is as of the 26th of this month, is all blood banks are recommended to start screening. And there's been 11 states, Louisiana included, that have been called to initiate this within the next 4 weeks, which is a giant task to ask for. There's 14 million units of blood donated a year from about 7 million people. And so obviously this is going to cost a lot of money. It's going to take time to initiate this, and it limits already precious resources if you can't use certain blood. Puerto Rico, for example, is having to import all of their blood right now because they don't currently have a screening process that's fully in effect, and so they're just importing every single unit of blood right now. From lab exposure transmission, there's prior than this current outbreak, there were 4 reports of laboratory acquired infections. There's 1 currently in the United States, and that was around June 15th. So what's the big deal for us? Mainly it's the microcephaly, the birth defects, that we have to really counsel our patients on. This is a baby that was born after the mother contracted Zika virus. So it can cause fetal death, neonatal death, it can cause spontaneous abortion, microcephaly, nervous system, central nervous system problems, uteroplacental insufficiency, growth restriction. Among other things, it's not fully known the scope of the disease, but it does have significant morbidity and mortality to infants. Here's a picture just explaining microcephaly. Basically just the head circumference is a lot smaller. There's different degrees of microcephaly, and the head size typically corresponds with brain size, and that's where you get a lot of the neurological dysfunction associated. And there's really no known relationship between the severity of the illness versus how severe the symptoms are. There's not enough data yet, so you can't really counsel patients that you're asymptomatic, so it probably won't be a bad infection in the fetus. There's absolutely no knowledge of what degree of the virus, or if you just need to have it and you can have any range of effects from it. So you have vision problems, hearing loss, you can have impaired growth. There's, as of right now, no known risk for future pregnancies. But currently in the U.S., in the District of Columbia, there's been 16 infants born with birth defects of various kinds. There's been 5 total pregnancy losses. This is as of August 18th. Talk a little bit about Guillain Barré syndrome. So this became an issue because people were noticing that in areas where there was a Zika outbreak, there were also in much higher rates of Guillain Barré. So currently they're saying there's a strong association. They're trying to find out the exact link, but we know that Guillain Barré is autoimmune mediated. It is rare. And the symptoms are weakness, arms and legs. It can affect your breathing if it ascends all the way up to your diaphragm. It can last weeks to months. Most people make a full recovery. It's rarely fatal. Those are in the cases where it goes all the way up to the diaphragm. So for Zika currently, there's no FDA-approved test, but in light of just the epidemic and the emergency of the virus, they've allowed one company, there's a PCR test that has gotten emergency approval, but it hasn't gone through the full testing that the FDA normally likes to see. There's a blood or a urine test. You can also sample infant serum, umbilical cord, fetal, and placental membranes. And there's extremely specific instructions of who to call, what size samples, the amount, what temperatures to keep them at. So that's why you have to report before you test so that you can get all of the specific instructions on what sample is recommended and how to prepare it and where to send it as well. There's an IgM serology test also, which can be used, and currently they don't really recommend testing blood, semen, or urine to assess how likely someone is to pass the disease on, because there's no data on if you have a certain level, if you have a certain titer, does it pass on or not, and so there's no testing for that right now. So who to test, what tests to do? In symptomatic pregnant women that have had likely exposure, they recommend doing the PCR test of serum and urine, and you're supposed to do it less than 1 week to less than 2 weeks from when symptoms began. In asymptomatic pregnant women that have been exposed or have likely been exposed, they also recommend serologic and urine testing within 2 to 12 weeks after the last date of exposure. And then in asymptomatic women who live in areas with active transmission, you can do the IgM testing as a routine lab during the first and the second trimesters, and then if it comes back positive or equivocal, then to proceed to the PCR test. If you have a positive PCR, then that gives you a definitive diagnosis. This is an algorithm of what I kind of just went through, but it's something that we could easily print out in clinic. It's from the CDC, and so it's an easy chart to follow if you have any questions about when you should test and what you should do with the results. These are recommendations on how to manage pregnant women. So if you have a recent virus infection, you're supposed to do serial ultrasounds every 3 to 4 weeks to assess the anatomy and the growth of the baby. You can also consider an amniocentesis, although there's zero data on this. And then postnatally, you can send cord blood samples, infant serum samples. You can do the testing. And then obviously if there's a fetal loss, they also recommend that you send the fetal tissues for testing. And then the rest of the chart kind of goes through the previous algorithm a little bit, but same thing. If you assume Zika virus, you can still do the ultrasounds, you can still do the tests. It's very similar whether they've actually had it or whether you suspect it. So for pregnant women and their partners, basically very similar to the previous slides, but if you have symptoms within 2 weeks of traveling, you should automatically be tested. Basically, everyone should be tested. If you've been exposed, if you have symptoms, if you don't have symptoms, you should definitely be tested. And then you should also be offered during your first prenatal visit and in a repeat test in your second trimester. There is no treatment for it. It's just symptomatic treatment. Rest, fluids. They recommend taking Tylenol for fever and for pain, joint pain. They don't recommend taking aspirin or other NSAIDs until you rule out. Obviously, in pregnancy, you don't want to use NSAIDs anyway. But in other patients, you don't want to recommend NSAIDs or aspirin until after you've ruled out dengue, because there's a bleeding risk there. For people that are considering getting pregnant, current recommendation is to wait at least 8 weeks after symptoms began before you try to conceive. Personally, if I had Zika, I would probably wait a little bit longer, but the current recommendation is 8 weeks. And then for men, wait at least 6 months, because they have incomplete data, but they know that Zika can be transmitted in semen longer. Yeah. And for asymptomatic men and women who have traveled to Zika areas, wait at least 8 weeks. So obviously you should discuss this with your doctor. They'll give you recommendations. This is just in chart form, the 8-week rule or the 6-month rule as far as when to start trying to have a baby if you've been exposed or have had symptoms. For reproductive age, people that are not necessarily trying to conceive at this time, obviously contraception is the best thing, but you can still transmit it if you use anything other than basically diaphragms and condoms. Protect yourself. obviously wait to attempt conception past those 2 time limits. And then the high-risk areas, they're getting bigger and bigger as we speak. So just keep up to date as far as what areas are involved. If you're traveling to those areas or have travel planned, you could reconsider. Now to switch to infants and children a little bit, you should test infants, whether the infant has basically, if the infant has any abnormalities, you should test them, and also pay attention to the mom's testing results. You can use the PCR or the serology test. And there, like I said before, there have been no cases of Zika associated with breastfeeding, so tell all your moms to continue to breastfeed. Here's a chart from the CDC about infant management. So if you have an infant that has a positive or an inconclusive Zika test, then, as always, thorough physical exam with length, head circumference, weight measurements. They should have neurologic exams. You should look for enlarged livers or spleens. You can also look for any rashes, skin lesions, do a full thorough exam, eye exam. In utero, obviously, you can do the ultrasound, but they can also have a cranial ultrasound to assess brain size, and hearing tests, like I said. If you have infants with positive or inconclusive tests who have microcephaly that are consistent, then you want to consult a specialist, also a pediatric neurologist. You want to test for other infections that could cause similar signs and symptoms. Get routine labs, blood count, liver function, enzymes, and focus on other possible teratogenic causes as well. Long-term follow-up, they recommend hearing screens at 6 months of age, and then after that, if you have any abnormal testing, to continue with your testing, because hearing loss is one of the main things that's been found in infants with Zika virus. Pay attention to developmental characteristics. Are they making their milestones, or are they lagging way behind? So in HIV patients who can often be significantly immunocompromised, there does not appear to be any increased risk to these patients right now, although we know that patients that have a low CD4 count or are severely immunocompromised in general typically show worse symptoms and have worse disease than an immunocompetent patient. There have been 3 cases in Brazil. They had mild illnesses, mild fever, some joint pain. They all recovered completely, but there is the chance that with a low CD4 count or AIDS that they may develop more severe complications, and they should be followed very closely. So thinking about our animals and our pets, doesn't appear to spread to animals. It was first discovered in monkeys, actually, so primates can get it, but no other. There's been a couple reports of, I believe, like buffalo, I believe have had it, but there's been none in domesticated animals, pets, dogs, cats. But there has been reported cases of mild fever in monkeys in the 1940s, and that's how it was actually discovered. And then no reported cases in pets. So transmission to animals, the risk is low. And in animal studies, they've found antibodies as soon as 14 days since infection. And so that's kind of where the recommendation for the 2-week serology testing has come from. And then once antibodies develop, they've found that primates can no longer spread the virus. And there's been no accounts of microcephaly in monkeys or in apes. So final recommendations, if you can at all avoid it, just don't go to areas where Zika virus is currently. But as the area continually expands, now it's here, so I mean, we can't really leave home. But if you must travel, talk to your doctor, healthcare provider, take all the appropriate steps that you need to plan for travel. Bring all your long sleeves, your insect repellents. If your sexual partner travels to an area, use protection or abstain, and then protect yourself from mosquitoes. Very briefly, what we do here, if we, when patients come into clinic and they have to be screened, it's a mandatory screening that this pops up. It's one of those best practice advisories that typically the intake nurses will fill out. So it asks you questions, you have to fill out the screen. Based off of your answers, it then will give you suggestions from the CDC that are up to date. And it won't let you continue unless you fill out that screening. So if we do have a patient that we suspect needs testing because they've been exposed or they have symptoms, this is the person that is for the state of Louisiana that will approve the test. That's the phone number. At UH, Denise Taylor is the head of the infection control. And that is her phone number. So it's really important for this. It's a public health emergency. It's important to contact your local health department, which will, all of these steps will be in place as soon as you contact these people that are assigned to do all of this. But you want to report information about pregnant women. You want to collect as much clinical information as you can from them and about their infants. And then any adverse events, if they had spontaneous abortions, if they terminated their pregnancy, if they have any congenital malformations, because the United States and the world is tracking all of this. Patient resources. Basically, we are the best resources for our patient. They're going to come talking to us, asking us questions about this, whether we think they should travel or not, if they can wear insect repellent or not. So it's always best to be up to date on information. There is this mother-to-baby hotline, which patients can call, or they can go to the website to look up more information. And then the CDC website is coming out with daily updates. They have a lot of tools that you can print out, pamphlets, papers, posters. You can put them up in your office. You can hand them out to patients at your clinic visits. And that's about it. There's my resources. Thanks to Dr. Briette. And these are safe from Zika. Any questions? So right now, the plan is to do routine screening. There's a little bit of a lag as far as getting everything in place. But the recommendation is to routinely screen everyone right now.
At least in Puerto Rico?
Mm-hmm, in Puerto Rico.
What is the recommendation? Because I've had people ask me from like border cities about people who are getting married like in the future about getting the virus. I mean, you know, trying to get it, I guess, prophylactically before they start having kids or things like that, you know, so they don't have to worry about it later. I mean, is there any, I think there's no recommendation.
Yeah, there's absolutely no recommendations on that.
Yeah.
As of right now, because they don't fully understand or know how long the virus stays in your system, especially transmitted sexually, that I would say definitely do not do that because, I mean, it could be, they know it's, you know, it can be up to 6 months that you need to abstain, but it could be longer than that. They really don't have a whole lot of information there. There's a lot of studies just now starting, but it's going to be a while before those come out. So I would say definitely don't do that.
That's what I was thinking.
Well, yeah, I'm just, it's like, there's a lot of people who, they hear about the 6 months and they hear about all those things, and it's not like a cold virus where you can get the same virus, you know, over and over again, it seems like.
You don't get the same cold virus, you get a similar.
Well, right, exactly, but I'm just saying, like, that's what they're trying to figure out, is if you can get Zika multiple times in a row, and so if not, is there any benefit to that, I guess, is kind of that thing.
And I would say just with the risk of Guillain Barré, I mean, this is a rarely fatal disease. Normally it's asymptomatic, or you can have just a little fever, some joint pain, conjunctivitis, but I mean, there have been cases of fatalities from it. Typically,
Right, but it's still rare though.
yeah, it's still rare, but I would recommend against that personally. Yes.
Two questions. One, in your reading, what is the status of vaccination and specific treatment?
So right now, there's a couple companies they're in the process of developing something, but from what I could find, it's a long ways away. There's no data as far as when a vaccine will be available.
I believe the inactivated vaccine is phase 2 trial, where we do have some chemicals that design the molecules of us to act that is like other antivirals more specific to your The second question is, in your second slide, how many listed, maybe I misread it, you said something about colon transplant 9 times or something? Because that would have different implications, not just the Zika virus, there are a lot of in general things that might be irrelevant with cataract transplants or metabolic disease, collectonemia, so you might want to look into that.
Yeah, she had so many transplants that she now has just a glass eye.
Why would she have that? Why would she do that?
I don't know that, but we can most certainly look into it.
That was my
Our blood collection agency is currently refusing donations for people that aren't positive, like they did for being when I lived in England during mad cow scare and that kind of thing.
So right now, because the actual screening of blood is not in effect yet, there is a screening questionnaire that blood banks are using. Just if you've been to an area or had sexual intercourse with someone that's been to an area with Zika virus, they're doing the actual questionnaire right now. But the hope is within the next 4 weeks they'll be able to actually start testing blood. But it's just a lot of moving parts, and a lot of money has to be involved in order to get that.
And you have a lot of information about screening and pregnancy and things. What about those of us that are going to go, say, to a honeymoon in an area that may or may not have exposure and come back? Is routine screening going to be available a couple of weeks decide they can see if we can track this one?
So as of right now, no, but if you come to your preconception counseling and you've been exposed recently, anyone who's considering pregnancy and has been to an area or been exposed to it is recommended that they get tested. Right now you have to...
They'll be testing women.
Yeah, there's no male recommendations right now.
And it's, the testing that they're recommending, you said you got to call and get the specifics and stuff. Is this, especially for an asymptomatic, I've just traveled to the area, is it going to be something our lab's going to be able to handle, or all of this is going to be sent off?
All of it, yeah, it's all sent off. And it takes, the one that we tested, I believe we sent off the sample 6-7 days ago.
Takes about a week.
Yeah, it takes a while.
So this is state lab. How much does the testing cost, and does insurance or the party payers cover for it? Someone comes in and say, well, that's $500 and my insurance is going to cover it. I'm not.
Right, that I don't know. I haven't looked up how much it costs or who's going to pay for it if this becomes mandated.
Well, this is Congress appropriating money.
Yeah.
They're appropriating money for Congress, not for. Of course. They always project that.